Good morning, everyone. We are going to start in about 2 minutes. Good morning or good afternoon, everyone. My name is Saki Malik Cho from the National Center for Health and Public Housing. On behalf of the Corporation of Supportive Housing and the National Healthcare for the Homeless Council, I'd like to welcome you to today's webinar, Housing is Healthcare, Prevalence and Considerations Across the Housing Spectrum. This is a collaborative effort between our organizations, and we're really looking forward to discussing all the complicated issues facing our population. Our organizations all have cooperative agreements with the Health Resources Services Administration Bureau of Primary Care to provide training and technical assistance to health centers across the country. So it's with their support that we're able to have this webinar. But I must note that while we do receive funding from HRSA, the opinions that are expressed here are our own and do not reflect those of the Bureau. So before we get started, and I can see people are starting to join, I'd just like to go over some of the housekeeping items. We are recording this webinar, and we will plan to have the slides and the recordings available on our site after this is over. Because we are recorded, we've muted all of your lines, but we'd like to encourage you to use the chat function to ask questions or to make comments throughout the presentation, and we'll have a formal Q&A at the end of the presentation. You'll also have an option to raise your hand if you want to ask a live question, and you just click on the raise hand icon, and then we'll announce you when the line has been unmuted so you can ask your question. So thank you again for joining this webinar. Our goal is to highlight all of the different ways that housing acts as a social determinant of health by discussing some of the data describing the healthcare needs and some of the challenges of individuals as they move across the housing spectrum. And we also wanted to highlight the great work that health centers and hospitals are doing to care for these patients and give you some examples of the types of programs that you might be able to implement at your organization. So these are the learning objectives that we've outlined. And to accomplish these goals, we're going to have an excellent panel of speakers today. We're going to start with the homeless perspective with Lauren Berner from the National Healthcare for the Homeless Council. Lauren is a research manager at the National Healthcare for the Homeless Council. She works with the research team to support the healthcare for the homeless field by developing and disseminating knowledge, as well as increasing the visibility of HCH-related research. Lauren holds a master's in public health and a master's in social work, both from Tulane. We're going to hear from LaWanda Williams from the Baltimore Healthcare for the Homeless. LaWanda Williams is the Director of Housing Services at Healthcare for the Homeless. At the downtown Baltimore site, she leads a team of 30 consisting of 5 distinct housing programs. And combined, these programs provide housing support to over 400 individuals. These programs provide a range of clinical services designed to help people obtain and retain housing placements by addressing the needs of people living with HIV and other medical disabilities, as well as those managing persistent and severe mental illness. She obtained her associate's degree in human services with a concentration in substance abuse counseling, and a BSW and an MSW with a concentration in public health from Morgan State University. Next, we're going to hear from Ian Costello for the supportive housing perspective. He is a program manager and analyst on the data and analytics team, which is part of the National Strategy and Impact team at CSH. Ian has been involved in a number of CSH's signature Fuse initiative projects across the country, using data to link frequent users of justice, health, and homeless systems of care to supportive housing. Prior to his work at CSH, Ian was the manager of the Performance Analysis and Reporting Unit at the Los Angeles Homeless Services Authority. That's the collaborative applicant for the LA Continuum of Care. There, he was responsible for project evaluation, performance analysis, data visualization, sorry about that, and dashboards, as well as all performance reporting responsibilities for the agency. And then we're going to hear from Ashley Shear. Ashley is the Clinical Operations Manager for Queens Care Coalition at the Queens Medical Center in Hawaii, where she leads a team of 22 social workers, navigators, and screeners. Queens Care Coalition provides intensive hospital and community-based navigation services to vulnerable people to connect them with the right care in the right place at the right time. Before her leadership role with Queens Care Coalition, Ashley worked as an emergency room social worker for 6 years, where she worked directly with patients and families experiencing crisis, death, substance use disorders, homelessness, and mental health illnesses. Ashley is very passionate about integrating a harm reduction framework into an acute care hospital setting. Finally, I am going to be discussing the issues related to public housing. Again, my name is Saki Malik Cho. I'm the Director of Research Policy and Health Promotion at the National Center for Health and Public Housing. I oversee all of our research activities, including data analysis of health conditions affecting public housing residents and qualitative research identifying best practices to improve access to care. I've been working on social determinants of health for the past 15 years, particularly on the intersection of housing and health. I received my doctorate in public health from George Washington University and a master's degree from Meharry. And then we're going to have our Q&A, and I'm joined by my colleague, Side Sandoval, who's going to help with that portion of the webinar, and she's also going to help with the polling questions. But I'd just like to point out that we have a pretty packed panel today, and I'm a little worried that we might not end up having a long Q&A portion. So I may have even gone past my 5 minutes with this intro. So I just really encourage you to enter your questions as they come to you in the chat box. And what we'll do is, in case we run out of time, we'll send those answers to everyone in the follow-up email. So now I'm going to pass this off to Lauren for her presentation.
Great. Thanks so much, Saki. Hi, everyone. Again, my name is Lauren Berner. I'm a research manager at the National Healthcare for the Homeless Council. Our cooperative agreement with HRSA is to provide training and technical assistance, but really aimed at improving the health and lives of people experiencing homelessness. And we do this through education, research, and policy analysis. I wanted to start with just a little bit of background. Our primary audience is Healthcare for the Homeless grantees, or HCH grantees. There are currently about 298 of them across the country, and these health centers receive funding under Section 330 to serve a patient population that's comprised of at least 75% people experiencing homelessness. So across all health centers in 2018, there were over 1.4 million patients experiencing homelessness, and likely more. That's likely underreported. Over 955,000 of those were seen by Healthcare for the Homeless clinics. That's about 95% of their patient population and about 2/3 of the total number of people experiencing homelessness served by all health centers. I just wanted to make sure that we're all kind of on the same page, so I put up a couple of quick pieces from the definition that HHS uses to define homelessness, and really it's that the individual's residence is temporary or unstable, which includes those who are living in shelter or transitional housing, staying on the street or in a car, or doubling up with a friend or family member. So it's really just a recognition of that instability that is used to define homelessness for the purposes of the health center program. I wanted to talk a little bit about kind of the people that are served by Healthcare for the Homeless clinics according to the most recent data that we have. Overall, they're mostly adults age 18 to 64. They're slightly more likely to be male than female. About 53% of the patients are male. They are also likely very low income and below 100% of the federal poverty line. And we also see racial disparities in homelessness and patients served by HCHs. So HCH patients are more likely to be African American than the U.S. population. So 29% of HCH patients identify as Black or African American compared to 13% of the U.S. population. Getting a little more specific with housing status, HCHs report a little bit more detail about where folks are staying. This mix has been relatively stable for the past several years, so it's a pretty good picture of where folks are at. We see that the majority of HCH patients are either staying in a shelter, about 26%, or doubling up, about 30%. This distinction is pretty important when we're thinking about care planning, as the resources for folks in these different situations may differ. Someone who's doubling up may have a little bit more control over their food access, or they have more access to a kitchen or refrigerator compared to someone who's living in shelter or on the street. This can change the expectations in your care plan when you're treating someone for a condition that might be dependent on food security or managing nutrition and diet or taking medications that require refrigeration or safe storage. So things like diabetes and hypertension really require this additional level of detail and understanding of your patient's situation to design an appropriate care plan that will work for them and setting them up for success. I wanted to briefly call attention to that other category. For the 2018 UDS data and before, the other category includes those that are living in supportive housing, and that'll tie into Ian's presentation in a little bit. We capture it here so that HCHs can continue to provide care to people who have transitioned into supportive housing and out of homelessness without that counting against the patient population requirements that they have. I briefly mentioned racial disparities on an earlier slide, and I just wanted to reinforce that. Here you can see some of the racial demographics of HCH patients. So 49% of patients identify as white. That's compared to 76% of the U.S. population estimate for 2018 by the Census Bureau. So it's an underrepresentation. When you compare that to the fact that 29% again report identifying as Black or African American compared to 13% of the U.S. population, it's a pretty stark contrast here. Additionally, 2% of HCH patients identify as Asian, 2% as American Indian or Alaska Native, 1% as Native Hawaiian or other Pacific Islander, 3% as more than one race, and 14% as unreported. The sizable percentage of unreported race may be in part because some individuals who identify as Hispanic or Latino might not personally identify as any of the races listed here and may choose to only report their ethnicity. And then some folks may just not feel comfortable reporting. So some kind of considerations around that. Looking at ethnicity, we see that 26% of HCH patients identify as Hispanic. That's compared to about 18% of the U.S. population. So again, we see a bit of a disparity here, and that is mimicked in the homeless population overall as well. So now that there's a little bit of background on kind of who Healthcare for the Homeless programs are serving, we want to look at what conditions folks are presenting with when they come to the clinic. For HCHs, the top diagnoses are overweight and obesity, hypertension, depression and other mood disorders, tobacco use disorder, and anxiety disorders, including PTSD. So this is looking at the Healthcare for the Homeless program, but kind of how does that compare to other health centers? So when we're looking at HCHs compared to all health centers, we see that some of the chronic and other physical health conditions are not more common among HCH patients as may have been expected. I will say that when I pulled the top diagnoses, many folks that I spoke with were surprised that overweight and obesity was a top diagnosis for HCH patients, since we know that many folks deal with food insecurity. And so while it's a top diagnosis, this rate is about 11% lower than the overall health center population, and that is a top diagnosis for the overall health center population. And while malnutrition is a concern and it's typically kind of thought of as being associated with being underweight, many of the foods that folks can access lack the necessary nutritional value and tend to be high in carbs, starches, and salt, which can kind of help account for this need. In the case of things like hypertension, heart disease, and diabetes, we see that the HCH population is not really seeing these at a higher rate, but some of these challenges that folks face in managing obesity can also impact their ability to manage these conditions. So they may not have control over key components of a common care plan, and things like nutrition can be an additional barrier. We do see that healthcare for the homeless patients have higher rates of conditions when we start looking at behavioral health, notably related to depression and other mood disorders, which was the third highest diagnosis among HCH patients overall, as well as alcohol-related disorders, tobacco use disorders, and other substance-related disorders. Behavioral health conditions may be a cause of homelessness. They may also prolong the experience, and they can also be exacerbated by the experience of homelessness. So, in addition, mental health conditions and substance use conditions often co-occur in general, and especially in this population. So treating this without housing is an additional challenge because folks are consistently experiencing higher levels of stress. They may be re-traumatized, and they lack stability, which really makes it more challenging to address the concerns. A survey in 2014 of health center patients overall did show that those who are experiencing homelessness are less likely than those who are housed to access substance use treatment services when they want it. So it's not necessarily that they don't want to access treatment, but there are kind of additional barriers to accessing that treatment, and some of those programs may have a set of expectations that are harder to meet when you're not housed. We also see higher rates of infectious disease, notably hepatitis C, which impacts 3.74% of HCH patients when compared to 1% of all health center patients. That's tied to that substance use conversation where higher rates of other substance use can increase the risk of hepatitis C. We also see a higher prevalence of HIV, and I also wanted to call out tuberculosis. And while the prevalence here is pretty low, it is more than twice that of all health center patients, and I think can be a call to address other communicable and respiratory diseases more broadly. And I think it's important to use data to understand the patient population, but it's only useful in relation to actual practice. So I'm excited to move into the next piece where we get to hear from LaWanda Williams about the work that Healthcare for the Homeless Baltimore is doing in providing care to people experiencing homelessness and those transitioning into supportive housing. So I'll let LaWanda introduce herself, and then we're going to have a conversation about her work.
Hi, everyone. Thank you, Lauren. My name is LaWanda Williams, and I am the Director of Housing Services at our Healthcare for the Homeless in Baltimore, Maryland, in downtown Baltimore City. And the work that I do is really centered around the provision of permanent supportive housing services for individuals who are exiting homelessness. We have a number of distinct programs that target our work on helping people to increase housing stability, individuals who are coming to us. We're helping to transition them from homelessness into housing, and many of those individuals we're working with have histories of trauma. They have a number of medical issues, and generally are individuals who may have been homeless for a really, really long time. And so we have a lot of intensive services that we provide that help to increase their housing stability.
Great. Thanks so much, LaWanda. For those on the line, LaWanda does incredible work and is very, very knowledgeable on the subject, and Healthcare for the Homeless Baltimore is doing just so many really great work things and trying to impact kind of that upstream causes of homelessness, and as well as addressing those that are currently experiencing. So I'm very excited to have her here today, and thank you for joining.
Yeah, thank you.
So the first question I have for you is just what are some of the special considerations that you have when you're providing care for people experiencing homelessness?
Sure. Yeah, I think the most important thing that we focus on here in our work is really the idea of trauma. We know that individuals coming to us, we have this premise that everyone who comes through our doors have an experience with trauma by the sheer fact that homelessness in and of itself is a traumatic experience. We know that many people who are experiencing homelessness have had other traumatic events, and the population that we work with, unfortunately, they are not fortunate enough to only have homelessness be the only traumatizing event. And so I think before anything else, we take a lens that trauma is a big part of the experience of being homeless. And how do we look at the work that we do and really organizationally with a trauma informed lens? So, how do we set up our milieu in such a way that accounts for the fact that we don't want to re traumatize individuals? How do we set up our programs and services and policies that take into account the fact that people have had really difficult lives, and we want to do everything that we can to be really responsive to that? And so that's one of the things that is sort of first and foremost on our minds in terms of the work that we do with individuals. I think another key thing that we consider very quite a bit in the work that we do is this idea of relationship building. Again, when we think about trauma, the one of the biggest things that takes a hit when you have traumatic experience is your ability to trust. And we know that before we can give a pill, before that we can give advice, before we can engage and offer this great service that we have, whatever that might be, there needs to be a certain level of trust and respect and relationship and alliance in the work that we're doing with individuals. And so we're very conscious of the fact that relationship building will be first and foremost. It's the thing that we go back to when there's challenges that come up that we have to navigate with working with clients. It's what we go to when we're working with individuals and introducing this great treatment plan that we think will be able to help someone manage or better manage, more effectively manage a situation that they're working through, be that medical or integrating into housing. We know that any service that we do or any theoretical framework that I bring is only going to be enhanced by the therapeutic relationship, and so that's very key. And I would say the other thing in terms of considerations is just this recognition that many of the diseases and processes that we see in the people that we serve are going to happen much sooner in someone's life, based on the fact that homelessness is really, really hard on one's body. And so one of the things that was really interesting when I first started working here 9 years ago was the fact that people really were dealing with arthritis in their 40s. And that was something that was very new to me as an experience. You typically would think of many of the disease processes that our clients see, you would expect to see them in late 60s and 70s, but we know that the incidence of those things for the people that we serve happen probably about 20 years sooner. So.
Mhm. Yeah, you mentioned kind of the concept of alliance and relationship building, and I think that's really important when we're thinking of folks who may have had some negative experiences in the healthcare setting, especially due to the stigma surrounding homelessness and mental health and all of that. So I really appreciate you bringing that concept up of the alliance and in relationship building and working together through that. I think that's so important. Can you talk a little bit about considerations for those who have moved into supportive housing?
Yeah, there are many. There are many. I'll take a moment to highlight a few. I think the thing that is most on the forefront of my mind, and I think some of this is regional, but here in Baltimore, one of the things that I'd be remiss if I didn't mention was the fact that we have a pretty significant opioid crisis happening in our city. And so one of the things that we are very much aware of is the fact that we need to be talking with individuals about relapse and overdose prevention moving into housing. I can't think of anyone in the last couple of years that we've moved into housing that that's not been a part of the conversation. oftentimes when people are using, and have made decisions that opioids will be a part of their life in some way or another, we have to really look at moving into housing as a really high risk time. People are moving from communities where they may have been using with others, using in certain patterns, securing substances from certain people in reliable ways, and moving out of those spaces and out of those communities puts people in a situation where they're now using alone potentially, potentially getting access to substances in different ways and from different people, and with a lot of the issues around fentanyl in our community in particular, it's something that we are very conscious of in our discussions with people as they transition into housing placements. So making sure that we talk with people in real time about things that they can do to mitigate some of those risks and really taking a harm reduction approach to the way in which we have those conversations. So it's really a matter of talking with people about making sure they have naloxone, trying not to use alone, the idea of going slow and starting slow, and really, and knowing who you're buying substances from, and trying to stay consistent if that's a choice that someone has made, to try to be as consistent as possible, so that they have at least to some extent some idea about the quality and consistency of what they might be using. So I think that's the first major consideration that we have. Another is really this idea that many people are housing naive. We work with a number of individuals who this might be the first time they've actually had responsibility for a place of their own. We work with a lot of clients who have have become homeless because of deaths in their family. There are many generations that live together, and so when grandmom passes away or mom or dad passes away, people sometimes find themselves homeless, and people have lived with family members for a really long time. And so we try to take this idea and have this appreciation for the fact that everyone doesn't know what we think people would intuitively know about what it takes to be successful in housing. And so really being patient with individuals. And I think to that point, really understanding that people will learn through trial and error. People who are moving into housing from homelessness will learn through trial and error, the same way anyone else learns through trial and error. You ride a bike, you fall off, you dust your knee, you might get a bruise, you get on it again, you try again. And so that's really the lens that we take with housing. We recognize, we're very clear about the fact that sometimes people will learn how to maintain housing, sometimes through losing a placement, and really having this idea that we just help people to learn from past opportunities for that learning, and to take that forward, and not being overly judgmental about those things, when you have an opportunity to learn through a past mistake. And then I think the other thing is really the idea that people often experience loneliness when they first move into housing, and to some degree have some measure of housing guilt. People don't say it in that way, but certainly we see that show up when we see things behaviorally, like letting other people stay in their units, as an example, or letting people store their things in their units, having unauthorized people on in their units that are not on the lease, and really, what it means to be with oneself, and which can be hard if you're accustomed to having people around. People don't always appreciate the fact that even though they've stayed in a shelter, and they've not liked that experience, that being in housing, and being alone and being with oneself, can also bring other challenges.
Great, thank you. Yeah, I think those are really important considerations. I think we always get excited when someone moves into housing, but that's just the start of a new phase. It's not the end goal.
Absolutely.
So how does your team address some of the access to care needs among your client population?
Yeah, so we try to provide wraparound services, and we do a lot of that here at our clinic. So we know that people have difficulty accessing some mainstream services, and I think part of that is, we think about individuals who might be homeless or have had experiences with homeless and now have transitioned into housing. and what that means. And our systems oftentimes have a lot of barriers or regulations that don't necessarily, or that sort of suppose that you have control over your schedule. And I often say that being homeless is a terribly busy life, in one that sometimes you don't have a lot of control over. So your time in terms of being able to access things is oftentimes predicated by when a shelter might bed might be available or when the soup kitchen might be available. And so I think having services that are as flexible as possible and trying to have as much as is within our scope to do here in one location, I think is very helpful to increasing access. So at our clinic, just to share a bit, we have a number of comprehensive services. So we offer dental services here on site, medical services, psychiatry. We have psychiatric OT services here. We have behavioral health and addiction programming. We actually even have partnered with the Department of Social Services in our community, and we have a DSS worker here on site to help with benefits and access to income. We have enrollment and benefits assistance workers who can help people to apply for medical assistance. We have pediatric clinic for families that we might be working with, and have a number of opportunities for community engagement and advocacy here. So I think by having a lot of services here on site, it helps obviously to increase access. And I think sort of conversely with our permanent supportive housing program, one of the things that I think has been critical is our ability to be out in the community. Most of our providers spend about 50% of their day out in the field. So we are going to where our clients are. So for people we're working with who haven't yet transitioned into their housing placements, we're going to shelters, we're going to wherever they might be in the community to provide those services if they're not able to come to us. We're also going into people's homes once they've secured housing and really being able to meet them where they are. And I think that ability provides a deeper richness to treatment planning and relationship building, being able to, and it certainly helps to decrease some of the stigma that individuals feel. And I think some of the power differential that can come up when, as a person coming in seeking services, having to sit in front of this person who has a tremendous amount of power, much more than the client. And so I think being in their space can help to increase access. And I think, the way in which we do that is through a multidisciplinary team. We have therapist case managers on our team who work with our clients and provide any mental health services and the intensive case management that folks need. And we have peers that work on our team who have a lived experience that is similar to some of the experiences that our clients have had. So we've found those things to be quite helpful in terms of increasing access to care.
Thanks. I think we are running low on time, but I just wanted to say if you could share like one or two of the care needs that you see when someone is transitioning from homelessness into supportive housing.
Yeah, so I would say certainly I think one of the biggest care needs is medical. People often have not been able to prioritize those things just by product of being transient, not having certain documentation they need to enter into medical systems. I think the ability and time and attention and transportation and all of those things that impact someone's ability to get into medical care have been significantly compromised, if not completely ameliorated by the homeless experience. And so I think that's one of the big things. And I'll end by saying that I also think that while not a medical care need, I think an emotional care need that actually comes up quite often with folks that we work with is the need to develop and establish supportive networks. When people move into housing, they leave a community behind. And that can create all kinds of feelings in terms of emptiness and loneliness sometimes, and certainly increased depressive symptoms that people have. We know that the antidote to depression is not happiness or medication. In many instances, it's really connection. And so, how do we be intentional about helping people to establish connections, healthy connections with people, because we really are social creatures. So.
Great. Well, thank you so much, LaWanda. I really appreciate your perspective in this. And at this point, I'm going to hand it over to Ian to talk more about supportive housing.
Hello, everyone. Thank you so much, Lauren and Lawanda. That was a really great conversation. I was nodding my head and saying throughout the entire conversation, so thanks for the great segue. My name is Ian Costello, and I work for the Corporation for Supportive Housing, and I really appreciate that great lead-in. I want to talk a little bit more about supportive housing and the data that we see and that we need to really understand the needs of people that are living in supportive housing and how it affects their health and health outcomes. Here's the slide. So I just wanted to talk a little bit about supportive housing very briefly, and then I want to talk about what health outcomes in supportive housing research is out there and also the policy perspective around it, and also talk a lot about the data gap that exists between supportive housing and health outcomes, as well as what you can do and what we're doing to come up with solutions and close that gap, and give you some resources. So very briefly, and this is from the CSH website, supportive housing is an innovative and proven solution to some of the community's toughest problems. It combines affordable housing with services that help people who face the most complex challenges to live with stability, autonomy, and dignity. So this will probably be the last time that I read from the slide, but I just wanted to make sure that I could baseline everybody. The most important thing to know about supportive housing is that it has a lot of evidence behind it, and it's an effective and needed resource in communities to end homelessness for people with complex health and other barriers. And while there is some nuance, there's also a lot of evidence that supportive housing positively impacts not only one's housing stability and overall health, but also some of the chronic health conditions that people may experience while they're in supportive housing. So I just want to say that this isn't just me saying all this stuff before now and now. There's a lot of research that exists around supportive housing and health outcomes, and we'll get into some of the meanings behind all of it a bit later. But I want to share with you two really great resources that I leaned on quite heavily in putting this information together and drawing conclusions from it. So the presentation is guided in large part by these two resources, particularly the National Academies evaluation, which is an aggregation of critical studies and discusses a lot of the evidence and comes to some conclusions about the results from the data. I highly recommend it. It's not a quick read by any stretch, but it's a great primer on this topic and the complicated nature of research in this area. And then secondarily, CSH put together a great resource around the state of the literature for supportive housing. It's quite recent, coming out last year in 2018, and puts together, I think, 24 or 25 different studies around supportive housing and health outcomes. So if you like all that stuff, I absolutely recommend digging into that as a start. So a little bit more on the research. The committee, the evaluation committee from the National Academies, their review of the evidence of the impact of supportive housing for health outcomes found that those offered permanent supportive housing and tailored medical and case management services retained housing at higher rates than peers and control groups. Both randomized control trials, which is the gold standard oftentimes for research, and observational studies supported the housing first and PA-based models for those with chronic illness to achieve and maintain housing stability and independence in housing. These findings related to health outcomes in supportive housing are less conclusive, but not altogether negative. So the brass tacks of everything is that permanent supportive housing is really beneficial to ending someone's homelessness, particularly those with higher health needs, and overall improves someone's general health. They showed that it went. They showed that they were less dependent on emergency medical services while in supportive housing, for example. But there's a lack of data that makes it really difficult to understand individual health conditions and whether or not supportive housing, to what extent supportive housing was able to impact positively those conditions. There was some success that the committee did note around HIV/AIDS and how supportive housing helps with, as Lawanda was saying, helps with a lot of the maintenance of someone's health, where There's access to medication more regularly. There's a lot of more human contact with case managers and so with someone in supportive housing. And so medical compliance within the community of people living with HIV/AIDS there was some success there. And I just want to be clear around what I'm saying about the data is that this is a data gap. It's not that the data shows that there are negative correlations between supportive housing and health outcomes. That's just not true. Supportive housing does work. It does end people's homelessness. It does improve their stability in housing. It does improve their overall health. But we need more data to understand and adequately explore how supportive housing is impacting specific health outcomes. So a little bit about that data gap. What's important here, and this comes directly from the National Academies evaluation, they lay out in great detail a lot of the specific things that are needed coming up for how to understand this issue. And the first thing I think to bring up is that the tools and definitions around homelessness, around supportive housing, around prioritization, there are some really large gaps from community to community that makes it very difficult to expand or extrapolate toward a national or systems level approach, particularly because we rely so much on academic colleagues to do these evaluations, and for us on the more administrative or data analysis side to draw conclusions on a national scope, and that's really, really difficult. So there's not a lot of national data sets out there that we can use, so we have to rely on these piecemeal individual community level studies. There's a lot of activity that's going around with academic and service provider partnerships, and that's something that's certainly to be encouraged. That's a really great partnership that has been growing, I think, in recent years. As well as just big data, I think social services in general are waking up to the need for data in general and using best practices within data analysis that for-profit and the business communities have been using for a very, very long time. So data visualizations, performance analysis, performance management, project management, all these sort of buzzword concepts are starting to seep into the social service realm, where we can apply data to make better programmatic and policy decisions and impact people's lives positively. And just the thrust of this is that the data that we have on a national level for us, sitting in our RV towers, it's not there yet. And so what I want to convey to you all is that there are things that you can do today, in the next couple of months, over the next couple of years, that can help, as a community, us close this data gap. One of the things we all love, I'm sure, UDS, and so quality and complete UDS submissions is one of the most important things that we can be doing, as well as leveraging those Z codes. Z codes are really important, and I think there's a cultural shift that could happen to improve how we collect data on some of those diagnoses. But data is really valuable, and it should be considered a strategic asset in your organization. And this comes straight out of one of our partners' webinar series around data-driven culture called High Tech. I absolutely recommend their series as well about how to grow data-driven culture within your organizations, how to use data appropriately. They talk about making data a strategic asset. It is money in the bank. It is really important that you use it. Let's see. And then lastly, just some things on the horizon. So there is UDS data improvements coming up, if not already being implemented. Lauren alluded to that in her presentation, how we're adding in supportive housing as one of the key components that we're collecting on. The problem with UDS data is, if you don't already know, it's really hard to disaggregate by demographics across those populations. So we know how many people are in supportive housing, but we don't know what they look like, what their issues are. It's hard to interpolate all this stuff. And then the last thing is there's some data integration work that's happening that's more long-term around how do we integrate point of care and also system level data together so that it can help both administrators and also clinicians in their work and closing the gaps around someone's care. And hopefully, to put a much finer point on that, I'm so happy to introduce Ashley, who is up quite early in Hawaii to present on the Clean Care Coalition.
Hi, good morning. Thank you so much. I'm sorry, it's morning here in Hawaii. Thanks so much for having me, everybody, and thank you so much for the incredible conversations we've been having so far. As mentioned earlier, I'm a licensed clinical social worker and a certified substance abuse counselor, and I work at the Queens Medical Center in Honolulu. I love sharing our mission statement because I think it's kind of fun and exciting. I think we're the only hospital in the entire United States that was founded by royalty and continues to be funded by royalty. So that's our Queens Hospital's mission statement. We're a private nonprofit hospital in urban Honolulu, which is our urban hub here in the state of Hawaii. We're one of 3 ERs in Honolulu. We're the only trauma center in the entire Pacific Basin. And it's estimated that about 60% of people experiencing homelessness on Oahu, our island, are seen and treated at the Queens Medical Center. So as you can imagine, we're one of the busiest ERs in the state, seeing about 200 people per day through our emergency department. The fact that we see the majority of homeless people who are seeking medical care is kind of 2-part. One, the Queens brand is well known in Hawaii, and there's some brand loyalty there. And then also just our geographic location. We're right in the middle of 3 large areas of homelessness. So as mentioned earlier, I'm a direct practice service social worker by background. I was working in our emergency department for about 6 years, and I was seeing the same people coming into our emergency room over and over and over again with the same chronic conditions. And I realized that we sort of must be doing something wrong. If people are coming in with the same chief complaint and being treated and coming back in that day or that week with the same chief complaint again. So what I started doing was taking a look at some data, and I gathered some preliminary data on those patients who were the highest utilizers of our emergency department and those who were getting admitted to our hospital over and over again. And what I found was that about 80% of our highest utilizers were experiencing homelessness, and almost all had multiple chronic health problems. 60% had a substance use disorder, and about 60% had a behavioral health diagnosis. So that trifecta, as we all know, of substance use, behavioral health, and homelessness is causing people to, not feel great, want to get their needs met, and the emergency room was sort of their access point for care. In reality, we know that emergency room physicians, while great at saving lives and fixing broken legs, they're not great primary care doctors. They're just not. And so I wanted to develop a program that helped connect people to the right care in the community. And I realized really quickly that what was important was connecting them to housing and connecting them back into appropriate primary care. So our first step was to develop relationships with our local continuum of care and our coordinated entry system for housing, and then our area FQHCs, or federally qualified health centers. And what we did with our local COC was we sat down with them and looked at the by name list for housing. And we compared that to our list of the highest utilizers of the hospital. And what we saw was a staggering data gap there. The expectation was sort of that the most vulnerable people who are medically complex and seeking treatment in the ER sometimes daily would probably be really high on the by name list. But in fact, what we found was that, for example, the highest utilizer of the hospital that year, which was 2 years ago, had over 200 ER visits in a 1-year period and had $1.3 million total cost of care to Medicaid. He was number 80 on the by name list. So we realized that we wanted to be able to share data better with our continuum of care, and we wanted to be able to prioritize those people who were truly being missed and really, really sick and vulnerable. So we were able to partner with our COC, and that has made a huge impact in getting the most vulnerable medically fragile people who are experiencing homelessness into housing faster. And the other relationship that we wanted to develop was, like I said, with the FQHCs. And there was, quite frankly, not a lot of conversations happening between an acute care facility and the FQHCs beyond getting those ER reports that would be, faxed over or e-filed over. And there was often a huge lag in them getting claims data, so they didn't even know that patients paneled to them were seeing the ER as frequently as they were. So we started having monthly meetings with all the FQHCs one-on-one in our area to do real-time data sharing and care planning around why people are coming to the ER, how we can transfer care back to the community, and then just those everyday things like, hey, if this person's coming to the ER, let's not start them on 5 new medications. Let's redirect them back to their primary care clinic and have ongoing conversations about what sorts of treatment they need. Just to speak to some of the data that we've seen, we sort of saw the high utilizer population as just a necessary, sort of thing that we have to deal with as an acute care hospital. And nobody had really dug deep into what those numbers were actually looking like for our organization. So in 2018, there were over 6,000 patients who had 3 or more ER visits in a quarter, which was really staggering when we were able to pull that data and look at it. And it showed the argument for needing to start a program like the one that we started. 5,000 of those people are Medicaid recipients, and just over 1,000 of them are people who are experiencing homelessness. In our program, we've served 350 people since we started. 62% of those were experiencing unsheltered homelessness, and 65% of those obtained housing when they exited our program. And we did a lot of diversion. We didn't want to just rely on the permanent supportive housing vouchers through the state and the city and county. So we were able to return people to the mainland with family support, get people reconnected with family members they'd lost touch with. And some data that I pulled recently, and again, I know Ian mentioned it, but how data really is king. If anybody's worked with or for an acute care facility, you know that 30-day readmission rates and length of stay are kind of the 2 biggest areas that hospitals are constantly seeking to drive down. And in our fiscal year 2019, those people experiencing homelessness have a 13% 30-day readmission rate, and those not have a 9% 30-day readmission rate, with the average length of stay being 4 days longer for those people experiencing homelessness. So I think this just speaks to how much housing has an impact on healthcare and health outcomes. And it also was, this kind of data was perfect for me to be able to help our organization continue to fund our program. And I'm going to skip through because I don't want to take up too much time. I want to be able to allow some Q&A if possible. So I just to kind of piggyback on Ian, I'm somebody who was not data driven at all. I was a direct service social worker who loved telling patient stories. And I realized really quickly when wanting to start a program in an organization that I needed to speak the language of our CEO and our CFO. And that language is 100% data. And so now my motto is to pull on both purse strings and heartstrings. So if you can tell patient stories and have data to back it, I think it allows for all the exciting things that our program's been allowed to do. And I just want to also mention those Z codes again, and how being able to use Z codes in your organization, whether it's at an FQHC or an acute care facility or, a housing service provider, those Z codes allow us all to speak the same language and continue to, really stock up our data so we can continue to get excellent data to share out. And I'll end here so that we can get back to our presentation and some Q&A. Thank you so much.
Thank you. So now it's my turn. Thank you, Ashley. And I'm going to provide the public housing perspective. And I just wanted to note that I am looking at the time, and I hope that you guys can hang in there for the rest of our presentation. But I have a feeling that it might go a little bit over. So I hope you have some snacks. because this is going to be a little bit, probably around 15 minutes. Okay, so in case you aren't familiar with the National Center for Health and Public Housing, it's to strengthen the capacity of federally funded health centers that are located in or immediately accessible to public housing. And we do that by providing training and technical assistance, research and evaluation, and services to build outreach and collaboration. So we work directly with health centers and housing agencies to improve access to care and quality of care, and ultimately to improve the health outcomes of public housing residents. So there are 106 health centers that receive this special funding called Public Housing Primary Care Grants to help public housing residents. And about half of those PHPCs also have homeless funding. And in case you are curious about where the public housing buildings are in your area, you can go to our website. We have an interactive map that has the location of all the public housing buildings and their proximity to a health center site. Most recent UDS numbers, and UDS is a measure that health centers report to HRSA, so it's the Universal Data System. So that indicates that there are 385 health centers that are inaccessible to public housing, serving more than 4 million patients. But UDS uses a very broad definition when it comes to public housing, and we'd like to know whether you all are capturing that information. And to echo Ian and Ashley's point about collecting data, we thought we'd ask you. So FIDE is going to pull up this poll, and I'm going to give you a few seconds to answer. So FIDE, can you please let me know when that goes up?
Sure, one second. Are you able to identify and track patients according to their housing status? Check all that apply.
Okay, can you please let us know what the poll answer is?
Yes, so 62% say yes, we know which patients are homeless, 19% yes, 29% yes, and 38% none of the above.
Okay, so that's really interesting to know. Here's a little bit about HUD's public housing programs. This is traditional public housing that are operated by public housing authorities, not individuals that receive vouchers. So nationally, there are a little more than 2 million individuals that live in traditional public housing in the U.S. About 60% are female, about half have less than a high school diploma, almost 40% of the households have children, and the majority are living at or below the federal poverty level. An important thing to point out is that the number of traditional public housing units has been declining for the past 20 years. So HUD is moving more and more towards voucher programs for affordable housing and hasn't funded the much needed capital improvements to keep existing public housing units safe and healthy. So many municipalities are struggling to keep their housing stock or just demolishing it, which puts more and more people and more families at risk for homelessness. So there is some evidence showing that vouchers have improved health in some ways, but because there just isn't enough affordable housing stock available, in some cities, it makes those vouchers not worthwhile. And this is important because adults that receive housing assistance from HUD have a higher rate of chronic conditions and are greater utilizers of healthcare than the general population. So this is a report from HUD that links data from the CDC's National Health Interview Survey with HUD administrative data. And I want to point out just two things. The first is that if you compare the prevalence of these health conditions, you can see that the differences between public housing residents and the general adult population are quite significant. But there is another part of the story here, and that is also a difference when you compare public housing residents to other low-income renters. So even though receiving a housing subsidy might put a little bit less pressure on a household's income, you would think that the housing subsidy would act as a protective factor, and that's not what's happening here, which indicates that there are other factors in addition to income that are at play. For children that live in housing, HUD-assisted housing, they're living under the same SES demographics, and you can see that those kids are also more likely to visit the ER, miss school, or have a learning disability. And I don't have a bullet on this, but it's important to mention that they are also more likely to be exposed to lead, which is definitely linked to learning disabilities among other health complications. So when we talk about how these social determinants affect public housing residents a little bit differently than the general public and those that are homeless or in supportive housing, it's important to remember that, well, first of all, that individuals that are living in public housing, many of them are formerly homeless. So they may have been living with friends or relatives or living in their car or on the streets. So they carry some of those same experiences that Lauren and LaWanda described and some of that trauma. And there's also, as I mentioned earlier, just the shortage of affordable and subsidized housing all across the country. So some cities have wait lists that are 2 years or longer. And so as you can imagine, when someone is in public housing, no matter what that neighborhood assets might look like, whether it's safe or whether it's volatile, they're likely to stay. And I think that's important to consider just how much agency these individuals have. There's not a lot of choice in where you live, what foods you have access to, whether you feel safe to walk in a neighborhood or let your kids play in the playground. And it definitely contributes to the amount of stress that people feel, and it's one of the many reasons why diabetes and uncontrolled diabetes is so pervasive among public housing residents. So limited income, lack of transportation, access to healthy foods, safety, those are all challenges for low-income populations. So that brings us to our second polling question, which is, Fide, can you please bring that up?
Do you screen for SDOH needs?
And so we focus just on housing for this poll. Okay, Fide, can you let us know what the answer is?
84% said yes, we screen for housing needs. 16% said no, we currently do not screen for housing needs.
Okay, that's great. And we're interested in housing, but on all the other screening, SDOH screening, that's important, but we just focused on that one for that poll. So now I'm going to switch gears and talk a little bit about some of the programs and the promising practices that health centers have engaged in to improve access to care for public housing residents. And these come from some qualitative interviews that we've had with both C-suite and clinical and non-clinical providers at public housing primary care health centers. So just going back to the diabetes issue, we asked health centers how they were implementing programs that address the underlying issues related to a healthy diet. So in this report, health centers describe some of the nutrition education classes and wellness programs that they've developed, like teaching people how to read a nutrition label or a cooking class, or how to navigate the grocery store, or using those veggie buses to bring in some fruits and vegetables into neighborhoods, as well as some fun exercise programs. But what the health centers did note is that public housing residents are really hard to reach, and getting people to attend those meetings can be really difficult. So in addition to that care coordination piece, having a nurse or a case manager follow up with a patient and enroll them into the classes, if they have A1Cs greater than 9, there are also a number of strategies that I've called out just to help improve attendance. And those are giving patients a call directly rather than relying on patient portal messages and emails. I know that might work for some other patients, but there is a broadband and a technology gap in public housing communities that makes using phone calls a better way to reach them. Even though sometimes people switch their phone numbers, it's still a little bit better than using those patient portals. Providing transportation, or better yet, coming to them. So we've talked to health centers that have developed partnerships with their local housing authority to allow them to have programs on site at no cost through lease agreements. So often housing developments have a community room that can be used for these types of activities. So take advantage of that if that's available in your community. Also, keep the schedules of patients in mind and try to offer classes, when they're available to attend, and if possible, offer childcare, and if not, make the classes family friendly and involve children. So another key component to managing diabetes is exercise, but that can't happen in an unsafe environment. Violence is higher in communities where there are limited economic opportunities, and exposure to violence often increases vulnerability to a lot of other mental and physical health problems, right? It's associated with heart disease, cancer, lung disease, diabetes, substance abuse. So we asked health centers to share some of their violence prevention and intervention programs. And rather than kind of go through them in detail, I just wanted to call out a couple of things. And the first is strategies for building trust, just to echo, what the previous panelists mentioned. Those are really important. Building trust is incredibly important for many reasons, and most importantly, just getting people into doors to access services. It takes a lot of time and it takes a lot of thought and how to create opportunities for the community to get to know you and what you can offer them, as well as being really clear in communicating and setting appropriate expectations, particularly if you are screening for SDOH needs. What do you do with the information once you have it? So this report also outlines strategies for addressing violence, including staff training, having safe spaces, and also some really great youth programs, create partnerships with other organizations. So I'm just going to talk a little bit about one case example that I think is really relevant here, and it's a program at Genesee Health Systems in Flint, Michigan, and that's a city that's been hit pretty hard by the opioid epidemic. And this is in collaboration with the criminal justice system. It's partially funded through a grant from the State Department of Justice. So drug courts, mental health courts, and veterans health courts, they've all been put in place to address some of the underlying issues of violence in the community. And in this partnership, there's a health center staff member that's embedded in the drug court and mental health court. So every day, that staff person reviews and screens the police reports and cross-references them with the patient list from the health center. So that requires, obtaining permission beforehand to share that information. But individuals that have been arrested that also suffer from mental health illnesses are put into an expedited hearing process, which remains confidential. So the hearing is set with immediate bail if that individual agrees to get treatment at the health center or at some sort of mental health or substance abuse services. And charges are dropped and wiped from their record if they complete their treatment programs. So there's two good outcomes of this drug and mental health court system. So first, it allows individuals to get out of jail quicker. And second, it allows them to get into the appropriate services that they need much faster than if they were to navigate the normal criminal justice system. And there are some folks at Michigan State University that evaluated the program, and they showed a reduced rate of recidivism that resulted in savings across many agencies. And this is also incredibly important because individuals that have been convicted of crimes are not allowed to live in subsidized housing, so they lose their housing status. So in some ways, this program also acts as a homeless prevention program. And I also wanted to draw your attention to this case example because by highlighting just the diverse group of community partners that can improve health, public housing residents, in addition to just health agencies and housing organizations. So that brings us to our third poll question, which is on collaboration. So Fide, can you please bring that up?
Do you have any partnerships to care for patients that are homeless, live in supported housing, or public housing residents?
Okay, let's close the poll.
40% yes, yes with social service agencies, 40% not yet.
Okay, great. So this is our summary slide, and I apologize that we're so far over our time limit. I just wanted to list that some of the important concepts that we discussed today, including the importance of identifying patients according to their housing status, screening for SDOH needs, creating partnerships, but also particularly as health centers move towards this value-based care. It's important that we track interventions and outcomes and identify payment models for reimbursing that care. It's also important that health centers are staffed appropriately. Health centers often rely on care coordinators or case managers for vulnerable hops. And I also just wanted to mention that it's also important to consider your IT staff to develop some of all of those back-end programming that's needed for EHR systems. And finally, suggestions to improve reach is having a flexible practice and addressing patient needs as comprehensively and as quickly as possible. I want to point out a really valuable resource that's available. It's called the Health Center Resource Clearinghouse, healthcenterinfo.org. This is a one-stop shop for health centers to get all of the training and technical assistance materials that are available by the 20 organizations that are funded by HRSA to do that, including all of the organizations here today. So if you haven't already, I encourage you to explore that site. I know we don't have time for Q&A, but there are some questions within the chat. So if you want to add those questions, I promise we will try and address those in a follow-up email to you. I want to put up our contact information so that you have that. And you feel free to reach out to any of us if you have further questions. And finally, I'd like to thank all of the fantastic panelists that we had today for their presentations, and I'd like to thank all of you for joining us and sticking with us for the extra 10 minutes and for all of the amazing work that you do. So just a reminder to please complete the post-evaluation survey that will pop up at the end of the webinar, and again, please feel free to contact us if you have any questions or if you have any additional needs. Thank you all so much.